At this time, I'll go ahead and hand it over to you, Dr. Tsai. Thank you.
Thank you so much. Can everyone hear me okay? Can you hear me okay, Kayla?
Yep, I can hear you great.
Perfect. So I want to thank everyone, first and foremost for taking their time out. I know everyone has their, very busy schedule, and it's quite an honor to be here presenting on behalf of Body Vision. Tonight I do want to make sure that this is, a talk where we can actually be interactive, have all our audience members, ask their questions, and hopefully I can answer them to the best of my ability. But I essentially want to take the time tonight to describe my own personal experience with our lung cancer program as it comes to robotic navigation bronchoscopy, and more importantly, the AI-driven tomography that really helps us aid the accuracy and diagnoses of these very deadly cancers here. Just a bit of background, we all know that lung cancer is an extremely, extremely deadly disease. In fact, it is the #1 cause of all cancer deaths when you actually compare it against all the other cancers that we know are high in prevalence here. Currently, there's about 2.2 million new lung cancer cases in the world. And out of those patients in the United States, about 240,000 patients are diagnosed annually in the United States. It actually accounts for close to 25% of all cancer deaths. And if you take a look at that and you take all the incidence of colon cancer, breast cancer, prostate cancer, and you combine it, lung cancer still supersedes the mortality rate of all those other cancers, which again drives home the point that we must understand that currently lung cancer still is the most deadliest cancer that our patient can be afflicted with. Back in 2015, there was only about 4.5% of patients out of 8.5 million United States patients who were actually eligible for lung cancer screening due to smoking. We know we subsequently had, an increase in a laxing of the indication for lung cancer screening. And currently now in the United States, there's probably about 15 million to 20 million Americans who are actually eligible for lung cancer screening. But quite honestly, it is a woeful low number of Americans who are actually getting lung cancer screenings. And out of those 15 million to 20 million Americans, there's only about 450,000 to 500,000 Americans who actually completed their lung cancer screening. So it begets the problem of, the question, of course, the problem that we have with lung cancer screening is that a majority of patients in the United States who are eligible for lung cancer screening are not getting their screenings. And this may be a big problem and a big detriment to why we cannot improve the 5-year survival rate of these patients. When you take a look at these patients, up to 65% of these patients are diagnosed at stage 3 and stage 4. So we're talking about local regional disease as well as metastatic disease. And when you combine that, the overall 5-year survival rate is still dismal, less than 10%. Overall, the 5-year survival rate for lung cancer is about 65% to 70%. And when you take a look at that, quite honestly, that is the only one cancer that we have not been able to really move the needle on improving our 5-year survival rate. And I do think that partly it has to do with #1, the low numbers of lung cancer screenings that patients are taking advantage of. But also #2, the problem in the past, before the advent of robotic navigation bronchoscopy and some of these other, sophisticated technologies, was that the threshold for trying to identify subcentimeter lesions for cancer was extremely limited because of the fact that as thoracic surgeons, as interventional radiologists, as pulmonologists, we did not have the ability to find these nodules because of the fact that they were so small, albeit very, very suspicious in nature, based upon inflationary guidelines, and of course your Mayo risk scores. Sorry, I'm just trying to scroll through this. My computer's, there we go. I'm sorry. The current challenges when I first acquired my navigation bronchoscopy, and as well when we started adopting, previously the super dimension bronchoscopy platform, is, as we know, the CT to body divergence. And the concept here for the audience, I'm pretty sure, is not very difficult to understand. Essentially, what we're trying to do is take a CT scan that was obtained on these patients, up to 2 months before the procedure, and we're hoping and praying that when we lay this patient on the OR table or in the endoscopy suite, that the position of these patients are going to mimic and match exactly what they were doing or how they were lying, how they were breathing on the day they had their CT scan. So unfortunately, we all know that, these patients have different, volume, tidal volumes, different motions, different positions of their arms. all these lead to a significant deviation from where the actual nodule is in relationship to that patient who had the CT scan done, weeks to months ago versus the day that they presented for the procedure to diagnose these cancers. And quite honestly, as we talk about, as I show in other papers, in the talk, this happens with all navigation platforms. And quite honestly, we have to be honest, it happens with all the three major platforms we know about: Monarch, Ion, NOAA Galaxy, as well as the legacy technology in super dimension bronchoscopy as well. And the reason why is because of the fact that everything is relying on that initial CT scan to really set that initial navigation target. And so if we look at the studies, the difference between preoperative CT scans and where the actual lesion is located is significantly divergent, up to about 1.5 centimeters, with a deviation of about 1 centimeter on the average, with even up to deviations of close to 4 centimeters. And so what happens now is the fact that we are missing one of the most important things that's required to help increase the diagnostic accuracy of these procedures, and that's the tool and lesion confirmation. If you look at our interventional radiology colleagues, these guys have been improving their diagnostic accuracy as their technology gets better. And the one thing that's consistent in all their procedures is confirmation of tool and lesion via the CT scanner. And if you look at the transthoracic needle aspiration rates in the past, when I was a fellow in cardiac thoracic surgery, the past diagnostic yield for IR guided CT guided biopsies was about 82%, 85%, but they've increased significantly to about 92%. And those are excellent data for actually getting diagnostic yield and accuracy for these lesions. But again, we do know that there's other limiting factors for these cases. Of course, one of the biggest limiting factor are the nodules are still smaller. So there are very few interventional radiologists who are really going to try to go after subcentimeter lesions. And quite honestly, in the past, if CT guided biopsies yielded non-diagnostic or insufficient tissue or a negative diagnosis for these subcentimeter lesions, a majority of us in this forum would probably not believe that result, and we will still continue to put these patients on a surveillance program to make sure that suspicious nodule does not increase in size. However, the biggest problem that we have with electromagnetic bronchoscopies, and these are the super dimension systems, the variant systems, the Monarch systems, is again with that concept of CT body divergence. And if you look at here on a paper by Dr. Michael Pritchett, he's again one of these national figureheads when it comes to interventional pulmonology as it deals with navigation bronchoscopy. There's a significant deviation in the CT to body divergence when it comes to these systems that are based upon EMN. And so if you look at the bottom graph here, it's showing you in that red spherical pictograph that is where the actual virtual target center is on cone beam. So for example, as we're navigating down with whatever platform you have, that software is going to generate that pathway for us to be pointing at that red target. But unfortunately, in many of these cases, and we'll talk about that data in a couple seconds, is that you can see that the actual location of the target is actually off center from where the software is directing us. And this happens because of patient breathing. It happens because of patient positioning, tidal volumes that the patient's doing, and so on and so forth. These are all different aspects of why the CT to body divergence happens. And so if you look at that, what he's showing is the fact that on the right-hand screen here, where you see the column graph, out of 41 patients, the mean lesion size was about 2 centimeters. And again, these are pretty sizable lesions. 2 centimeters, for those of us who are quite experienced in robotic navigation bronchoscopy, 2 centimeters, we're getting very good yields and very good accuracy rate with 2 centimeters, and and I do think the technology aids us. But even with lesions that are that size, the percent of overlap between the virtual target and the actual target is pretty significant, significantly off center. So if you look at that, about 30% of the time, electromagnetic navigation is off by about 2 centimeters or more. That is huge. That is a huge deviation, at which time, we can definitely confirm that the tool is not in the lesion. And if the tool is not in the lesion, we can certainly guarantee that that lesion will not be in the tool, which is ultimately the endpoint that we all want to achieve here. 36% of the time, 37% of the time, the electromagnetic navigation is off about 1.5 centimeters to 2 centimeters. Another 25% of the time, it's off between 1 centimeter and 1.5 centimeters. And again, the minority of the time, close to only 7% of the time, electromagnetic navigation is off only within 1 centimeter. So there's a significant deviation with all these systems, which are based upon electromagnetic navigation on the CT to body divergence. And of course, there are other companies, of course, that says, well, hey, we're not based upon electromagnetic navigation. So, based upon a corollary, we subsequently must not have as bad CT to body divergence as all the EMN-based systems. But again, this was also studied, and the talk was about combining shape sensing robotic bronchoscopy with a mobile 3-dimensional imaging to verify the tool and lesion. And so essentially what these guys did, they took 28 navigations where the mean lesion size, it was smaller, but about 16.5 centimeters in the upper lobes and 16.8 millimeters in the lower lobes. And the median divergence between the actual target, the virtual target, and the actual target was about 1 centimeter off in upper lobes, and the median divergence between the virtual target and the actual lesion in the lower lobes. As we know, there's more variation in volume, changes in the lower lobe. That was up to 2 centimeters also in the lower lobes. So again, if you look at this, the drive home concept should be the fact that yes, navigation bronchoscopy systems have improved in technology, stability, reach, but the biggest problem happens to the fact that it still has not addressed one of the most important things when we're talking about procedures dealing with accuracy, and that is real-time targeting. And so, just to step aside here and give an analogy, the way I see all these amped up or super navigation bronchoscopy systems is as if, someone built this massive and phenomenal, fighter jet that can, go to Mach 4 or Mach 5. I don't know what the Machs are anyway, but it's something that actually has a phenomenal speed and maneuverability. But they forgot to put a targeting system on that fighter jet. So now when it's reached, the target, it doesn't have that. When it reached the enemy fighter plane, it doesn't have the targeting system to really, land its missiles onto the enemy. And I really do think that, with systems such as body vision, that is what really puts the targeting system on the navigation system. And without the combination of those two systems, navigation and targeting, I do think that it does dramatically influence the accuracy and the diagnostic yields of these procedures that we're doing. Here are multiple studies. Again, I don't want to belabor every single one, but if you could look at it, the average diagnostic yield, and again, I know there's different topics and discussions about what constitutes diagnostic yield. Some people, of course, will include inflammation. Some people will include histiocytes as being as part of the diagnostic yield algorithm. And of course, that changes the percentage wise. But overall, you can see that even with these platforms, without intraoperative imaging, without the targeting system, the diagnostic yield is still close to about 75%. And again, that does not touch the diagnostic accuracy or the diagnostic yields of the interventional radiologist when it comes to CT scans and transthoracic needle biopsies. And that becomes a big problem for us because now we have a situation where we know we're taking these patients to procedures that may have a lower diagnostic yield than what we know is probably considered standard of care when it comes to biopsying the transthoracic needle aspirations. And unfortunately, I do think that we need to do something better when it comes to making sure we get accurate with our diagnosis. And if you look here, the one thing that the interventional radiologists have demonstrated when it comes to intraoperative imaging is the fact that the tool and lesion is extremely, extremely important. And so you look at that, there are 48 transthoracic needle aspirations, and it had a 92.1% average diagnostic yield. But the problem with these procedures, as we all know, is that there's a significantly higher pneumothorax rate. 20% is quoted, 30% is quoted. I've seen, I think that as our interventional radiology staff gets more and more, experience at it, I can say I've seen rates as low as 8.8%, 10%. But either way, whatever it is, we do know that transthoracic needle biopsies of the lung does have a much higher resulting pneumothorax rate. And that becomes a big issue or a big problem with these patients, especially if we're delaying their time to treatment, their time to chemotherapy or radiation. And so we don't want to delay these patients because time is of the essence. And so the one thing that the interventional radiologist has is the elimination of CT to body divergence. Why? Because the patient is there on the table, the image isn't done at that time, and again, they can actually calculate and correlate for the coordinate for where the needle is going to go, so you can see this needle going into the lesion in real time. We don't have that. We did not have that with the other navigation bronchoscopy systems, and unfortunately, what it was there was a significant degree of guesswork as we navigated the bronchoscope to what we thought was a lesion, and we're hoping by basically passing that needle. We don't know exactly how deep we're passing it, right? We know the distance, for example, for a peri-view is 2 centimeters, but you're hoping that that 2 centimeters really equates to the center of the lesion when you're trying to direct that needle into the lesion. And so essentially what we do know is that real-time imaging enables true visual confirmation of tool and lesion prior to and during the biopsy. And this is the one factor that makes accuracy so important, is that confirmation. So this leads to a new technology by Body Vision, and it's a AI-powered imaging software, actually. And so what this company has been able to do is a delivered near cone beam CT quality intraoperative 3D images with whatever C-arm the hospital has. So it doesn't require that hospital system to purchase the SIOS or the the OEC or so on and so forth as a cone beam. And again, that's a significant cost to the hospital. I know when we were evaluating the SIOS spin, the portable cone beam CT scan, the prices on that cone beam was close to about 400,000. And again, there are very few hospitals who are willing to purchase a $800,000 robotic navigation bronchoscopy. And oh, by the way, let's add another cone beam CT scan, which could be anywhere from 400,000 to 600,000. That's not a great sell for the hospital, as we know that the margins for these procedures are diminishing as time goes on. And so what they do is the fact that by using this AI generated 3D reconstruction, it eliminates CT to body divergence because of the fact that we can see where the lesion truly is at that second we're about to do our procedure. And again, we're going to show case studies to demonstrate that. More importantly, it also allows and enables true visual confirmation of tool and lesion. And if we know the one advantage, for example, for endobronchial ultrasound is the fact that using the ultrasound probe, we can again identify where the lymph node is, and we can truly see our needle puncturing and going to that lymph node. So therefore, that is that concept of real-time confirmation of tool and lesion. By using Body Vision, we have that essentially the same exact premise or the same principles by which the Body Vision software will actually delineate where the lesion is. And while you're doing your biopsies, you can see the needle going through that lesion to again mimic what we're doing when we're performing endobronchial ultrasounds. And so again, by providing true real-time imaging with augmented fluoroscopy, this generates a much higher diagnostic accuracy than we had previously. Again, we're putting the targeting system on this really fancy jet that everyone has, but again, very few of these have true targeting systems. And so by using image-guided real-time navigation solutions, it can actually be used as a standalone solution without the added cost of purchasing cone beam CT scans to increase your diagnostic accuracy. And that is why this may be a very favorable option to the hospital systems, because of the fact that it keeps the cost of these procedures much lower, and again improves the diagnostic accuracy, thereby improving the quality of the program that we all seek to achieve here. How does lung vision work? Essentially, as we said, it's an AI-driven technology, and what it does, the algorithm takes all these two-dimensional images that are obtained when the X-ray tech will do a 30-degree to 30-degree RAO to LAO, meaning a 60-degree spin or a sweep of the patient's body. And essentially, it was like when we were children, we had these flip book cartoons, right? So we had still images, and as you flip through it, these cartoons will move in succession, and that's very similar to what Body Vision does. They'll basically take all these two-dimensional X-ray images, and they are able to generate a 3D confirmation, or a CT scan with 3D confirmation of where the lesion truly is. So if you look up here to the right-hand image, that is what your AI technology is driving, is something that very mimics very closely to what we're having for CT scans. Here is your tomography showing the lesion. And again, as you can see, this catheter, this bronchoscope is driving out to that lesion, thereby helping us improve the accuracy of our navigation. This is this is what we call augmented fluoroscopy. And you can see the software has drawn out or delineated the borders of that lung nodule. And now we can actually see our needle traversing to the center of the lesion, to the center of that nodule in real time. Finally, here is your 3D reconstruction of the tool and lesion here. And so, again, what you can see is this can help us really make sure that we're truly where we need to be. The reason why this becomes important is because in the future, I do think, as many of us in this forum, we do think that there's going to be a significant role in direct tumor injection of chemotherapy, ablation techniques, so on and so forth, to help battle against lung cancer. And without that confirmation of tool and lesion, center strike in the middle of the lesion, these modalities are not going to be effective. And again, this is why it's so important to make sure we stay ahead of the curve as we plan and we anticipate intraluminal or direct endoluminal treatment of cancers to happen in the future. As you can see, the question then becomes, well, can you find subcentimeter nodules? Because, if we're taking all these two-dimensional images, are the reconstructed images, are they going to be able to help us find lesions that are less than 1 centimeter? And so here's an example of a case that we had. And so as you can tell, this lesion is probably about 8 millimeters, on the axial view. As you can see, here is our body vision generated image. Yeah, you can definitely see that lesion, although it's less than 1 centimeter. Here's just a second case that we showed, again, showing you very similar sort of resolution of lesions that are sub-centimeter as well. The then next question, of course, becomes, well, can body vision see ground glass opacities? And again, I think one of these may be my case, but as you can see here, here are your 8.5 millimeter semi-solid cavitary lesion. And as you can see with the AI generated tomography views, you can definitely see the lesion. Here's a ground glass opacity in the left upper lobe. This is what the CT scan truly generated, truly showed. Again, there's your GGO. And yes, body vision can reproduce that same exact image on their AI-driven tomography images, thereby increasing the re-registration of where the nodule truly is, so you can truly navigate your bronchoscope to the center of that lesion. And so what did this really do for us? Does this really truly help? And again, the most important thing is, yes, we can see that by using, modalities of direct and concurrent intraoperative imaging, it does increase the ability to successfully diagnose our patients with lung cancer. If you look at diagnostic success rate, as I mentioned before, of diagnostic bronchoscopies, usually are about 70%, regardless of whatever navigation platform, by incorporating body vision. So that way we have real-time direct visualization or biopsying, you can actually increase your diagnostic yields to about 90%. And so recent lung vision data points showed a 91.1% diagnostic yield. When used in conjunction with the Ethicon Monarch robot, when used by Ion robot, it actually achieved a 94.5% diagnostic yield. And again, if you use that as a standalone platform, I've seen some amazing cases where people were just using a handheld bronchoscope, and by understanding their segmental anatomy, they can actually achieve up to about an 89% diagnostic yield when used without robotic platforms as well. And so this is a slide regarding the benefits of real-time intraoperative imaging for robots. We do know that navigation bronchoscopies offers multiple benefits of better stability, increased articulation, further reach. As we remember back in the super dimension, times while we're trying to do these biopsies, someone has to hold that bronchoscope still while you're trying to manage the room in terms of getting specimens and so on and so forth. Those little minute changes in the hand position can really change the position of the bronchoscope, because all those movements are transmitted to the down the camera, which again may change the position. So stability is a huge improvement on that. Now, when we add lung vision to robotic navigation bronchoscopy, again, by making sure we re-register the lesion where it really is in the actual position, it does help improve or eliminate the problem with CT to body divergence. Secondarily, it does provide tool and lesion confirmation prior to the biopsy. So what we do is when the needle goes out, and we've already checked what we call the ARIA views and the central views and the LAO views, if the needle is truly in that lesion, every time we do those different projections, then we do a spin to confirm three-dimensionally that we are in the center of the lesion. And again, that gives us significant confidence that we are truly getting center strike on these lesions that are 8 millimeters to 1 centimeter in size. And again, by using that augmented fluoroscopy component, it allows me to really understand how deep am I really going to push that needle. Is the needle getting into the lesion, or is it bouncing back and forth, or is it not getting close to the lesion? Because by understanding the borders of where the true nodule is, it can really help you direct the most important thing, or the highest variability in these robotic procedures is not the robot, it's us. When we're trying to introduce these needles or these catheters or these biopsy forceps into the lesion, the one variability is always the human factors component of how hard do I push this needle, how far do I advance it, is there a certain bend or deflection, and all these are things that by using augmented fluoroscopy, it really helps you address. So this is a case study from a physician who is an interventional pulmonologist. She was serving in private practice, serving 3 different regional hospitals. And as you can see in Pennsylvania, by incorporating her technologies, which included a navigation system, she was using Varon, but again, she used the augmented fluoroscopy and the direct and concurrent imaging using lung vision. She was able to increase her diagnostic yield from 79% to 89%. And then what happened was the fact that by increasing the quality of the work that she did, and this was emulated in my data, which I'll show in a second here, we can see that now that we have the confidence to go after these smaller lesions, we're going to be able to get more and more patients to be screened, to be diagnosed, and to be treated. And if you look, the number of patients that she had, increased significantly by 35%, 23%, 42%. And again, referrals to medical oncology. Again, that whole concept of a rising tide elevates all ships. Medical oncology increase, the referrals to medical oncology increase, radiation oncology increase, and of course, my personal favorite, thoracic surgery procedures increased as well. And again, if we talk about the business or the financial aspects of a lung cancer program, this generates a significant revenue to these hospitals, thereby supporting the fact that in order to treat patients, we have to diagnose them. And again, the only way to diagnose these patients is to get them to some modality where we can get cells on a slide to prove or disprove that these patients need further treatment. So one thing that I was directly looking at was also safety to my OR team, safety to me, and safety to the anesthesiologist. One of the direct and most obvious benefits of the body vision system over our cone beam CT scans is the amount of radiation that this room is exposed to. And so if you look at the average fluoroscopy time for lung vision, it's about 0.36. For the style spin, it's nearly doubled. And so again, the fluoroscopy time is significantly higher when we had to do cone beam CT scans. And again, I'm not a radiation expert or anything like that, but we do know that the average dose in doing those bigger spins, as well as the amount of radiation that each system emits, we're talking about 6 times to 5 times the amount of radiation that we're all exposed to in the room. Again, we do know that is significant. A lot of times, people are leaving the rooms during the entire, spin of the cone beam CT scan. But again, each one of those fluoroscopy times to try to generate visualization, it does add to significant radiation exposure. And quite honestly, that becomes potential problems that we can have. I know that, for example, I'm only 48. I needed cataract surgery at 48, and one of the possible causes my ophthalmologist told me was maybe radiation exposure because I did do fluoroscopy. So, those are things to consider, especially since we are the ones absorbing that radiation in the room, that maybe we should be more mindful about protecting ourselves as well as protecting our OR team as well. For lung vision, one of the reasons why we get a lower radiation exposure is because rather than the 180 degrees of spin that the cone beam CT scan needs, we can just do a 60-degree spin. And again, by using the AI technology, it can generate that 360 degrees 3D image of what we really need to do. It doesn't require certain specialties to really optimize and interpret 3D imaging. We had the Tsai spin in our facility, and again, I had one of the best X-ray techs there. He even struggled in terms of trying to get the correct angulation and so on and so forth of how the cone beam CT scan works, cone beam CT scan works. And quite honestly, with body vision, it really is pretty intuitive in terms of how we all in the room can quantify and identify where these lesions are and so on and so forth. Again, the greater flexibility of the software. This software works with any platform that the hospital has, whether it be a Siemens, whether it be a GE brand, or so on and so forth. So any of the fluoroscopies that the hospital has already, it will be able to be processed with the software of body vision, thereby saving a significant cost to the hospital. And again, finally, for me, I think it's so important to make sure that you're seeing the needle go into the lesion in real time. Same exact premise for endobronchial ultrasounds. And again, that's what really helps us understand how deep to push the needle. Is the needle going, directly into the center or to the side of the lesion? And you can't tell any of that unless that, yellow ball is drawn out for all of us to see here. This is my personal data at my hospital system. You can see that back in 2019, I did about 60 our hospital system did about 60 lobectomies for stage 1 lung cancer, about 9 lobectomies for stage 2 lung cancer. In 2022, very similar numbers. Then we acquired the robotic navigation bronchoscopy. And just like that interventional pulmonologist in the Pennsylvania system, you can see a more than doubling of the patients undergoing lobectomies for stage 1 and a doubling of patients undergoing lobectomies for stage 2. So you can see this direct impact on saving more patients, because we do know that the 5-year survival rate for stage 1 lung cancer fully resected can be up to 92%. I do think that by finding these lung cancers earlier and actually doing something about it earlier, that is the best way, or one of the easiest way we can make an impact in the improvement of the 5-year survival rate of lung cancer, is to find it when it's at stage 1, because of the fact that, again, as we talked about before, majority of these patients are identified at stage 3 and stage 4, where the 5-year survival rate is extremely, extremely dismal and low. So if we put it all together, what I wanted to do was to really drive, to my program, that quality of finding lung cancers earlier. And so the biggest thing that I did not want to do was to, essentially have these patients in that, that spinning wheel, I say, of referrals. So what we all know this happens, the patient gets a CT scan that's identifying a nodule. Everyone says, oh my God, you have a nodule. Let's get you to, the family practitioner, who calls them and say, hey, there's a nodule. I need to get you to someone to get this, taken care of. So again, we know that the referrals can be made to a myriad of specialists. It can be made to pulmonologists. It can be made to thoracic surgeon, medical oncologist, interventional radiologist. And again, that sort of referral takes about anywhere from 2 weeks to 3 weeks to happen, right? And then after that, for example, if these patients get their biopsy, then you're waiting for about 4 to 6 days for the biopsy results to come back. And again, if we talk about from the time that we identify the abnormal lesion on CT scan, a month has gone by already, and so far nothing has even happened to this patient. When we talk about staging these patients, of course, if the CT guided biopsy comes back as being cancer, then the referral is made to the thoracic surgeon and or the medical oncologist or the pulmonologist. pulmonologist will say, hey, we have to do an endobronchial ultrasound to make sure we don't have N2 disease. And you can see what happens with these patients. They spiral down this sort of, quagmire of referrals, where the most important thing we want to do is we want to make the diagnosis, the staging, and the treatment for these lung cancer patients so efficient that we're treating it in a single anesthetic event. So that's the reason why I really push for this in my hospital system. Is what I would do is that these patients who had a suspicious nodule would go to the operating room with the intention to say, on this day, we are going to be absolutely certain whether or not you have cancer or not. I think we've all been in that situation where we've done biopsies and we're all looking around and we don't have a diagnosis. We have pathologists telling us that, hey, all we're getting is bronchial epithelium and blood. And again, sometimes they'll say we see inflammatory cells, histiocytes, atypical cells, right? That is an entire sort of a black box, if you will, of uncertainty. And so nothing is worse than, having this patient come to the hospital, undergo general anesthesia, and we leave that room without a definitive diagnosis. So I want to make sure I address this in our program. Any suspicious nodules, we come out with a diagnosis. If this patient has a diagnosis of lung cancer, for example, that patient then gets flipped onto their side in the lateral position. And from there, we actually stage the patients using the robotic surgical system from Da Vinci. We'll stage the N2 lymph nodes. If the N2 lymph nodes are negative on frozen specimen, then we proceed with the segmentectomy and or the lobectomy, depends upon the size of the lesion in our hospital. So what we've really seen here in our hospital system, we've taken the entire, duration of onset of CT scans from diagnosis, staging, treatment, which what Medicare in the country is allowing to be 42 to 46 days. And we've taken that diagnosis, staging, treatment paradigm to about 4 hours. And again, I think that this is a one thing that we can do as a society who treats lung cancers to really make an impact in these patients, is to basically take that timeline and shrink it for these patients so we can actually help affect their 5-year survival. These are cases that I had, and so this is my first case that I had with the body vision. As you can see, as the cases go on, I go smaller and smaller. Again, this is my first case, so I didn't know what body vision was going to pick up. I didn't know really how to navigate my bronchoscope in relationship to this nodule. So I really want to make sure that, again, I did not leave this room, the OR room, without diagnosis. So this is a 69-year-old female. She was currently smoking. She had a 50-pack year smoking history, no previous history of cancer, and there's a solid 2-centimeter nodule in the right upper lobe. And then this was, again, as I stated, my first procedure using body vision. You can see, let's see, here we are. So you can see the lesion. I'm trying to see how to. Let's see if we can get that lesion to demonstrate here. There it is. That's it. For some reason, I'm not seeing. Oh, there we go. I'm so sorry. So here's a 2-centimeter upper lobe lesion. We can all basically have a pretty significant suspicion. Spiculated upper lobe. A little bronchus is close to that, and you can see the location of this lesion. This is the AI generated tomography, and you can see that lesion here. And so I was able to use the navigation bronchoscopy to navigate to this lesion. And again, it was surprising. Just like in the data that I showed before, we had about a 2-centimeter CT to body divergence. And again, we're a 2-centimeter lesion. We should be able to hit this lesion very easily because of the fact that the precision, the accuracy, the navigation, the reach, the stability of the navigation bronchoscopy system, we should be able to get this lesion. But again, in this situation, because there was a 2-centimeter CT to body divergence, we would never have achieved tool-in lesion. And so what I did, I used the body vision in conjunction with the Siemens Psyospin. And the reason why we had the Siemens Psyospin, because again, I was really wanting to compare both systems. So we had both of these systems in the trial basis. Furthermore, I was actually one of the 3 hospital systems in the country to be helping Johnson & Johnson with one arm of their LCI, lung cancer initiative study. So they required a cone beam CT scan to confirm tool-in lesion. But again, what we did, we compared the radiation exposure, body vision to Seaman spin. And again, we had a 70% or 1/6 the reduction in radiation exposure over a cone beam CT scan. Then I used Lung Vision's augmented fluoroscopy, the little yellow ball where I can see the needle going through it. I use that for image guided biopsy. And within my first pass of the biopsy forceps, my pathologist says, yep, you definitely have adenocarcinoma. And so the case, the total time it took me from bronch in to bronch out for this case was about 29 minutes. And we talked about 40 minutes from the time it takes to, position the patient, turn the patient over, and so on and so forth. So again, body vision really helped us increase the efficiency of our biopsy because we're not doing 5 passes, 6 passes, and so on and so forth. With this patient, within the first pass, we were able to get a confirmation of an adenocarcinoma. And so this patient, again, went into our single anesthetic event protocol. We turned them over for the robotic thoracoscopy, and 2 lymph nodes were dissected out and sent for frozen specimen. And again, all they were negative, so we proceeded with the oncological resection of that cancer. Case number 2. Again, we're trying to get smaller here. And I'm starting to understand the body vision a little bit better. I'm starting to understand how to navigate my bronchoscope in relationship to the re-registered lesion. And so this was an 81-year-old female. She was a former 50-pack year smoker, smoking history. And this patient had 3 different cancers. She had breast cancer, thyroid cancer, pancreas cancer. And she also had a solid 1.3 millimeter lesion, nodule in the right lower lobe. See if I can get us to show this here. And so let's see. Sorry. So this is the images taken. Trying to see if we can. There we go. So there's your 1.3 centimeter lesion in your right middle lobe here. You can see your coronal views, your sagittal views. And again, Lung Vision was able to pick that image up as well. Scrolling through, I think I saw it there. So if you pay attention to the right side there. And so again, what we were able to do by marking where the lesion truly was in real time, you can see my bronchoscope was probably pointed a little bit away from that area. And so I need to change the direction of my bronchoscope to be pointing towards the lesion now. You can see if we extrapolate the trajectory of the needle, I'm going to be missing that lesion significantly. And you can see what I was able to do was using the augmented fluoroscopy component, I was able to redirect the tip of that bronchoscope to be pointed centrally at that lesion to really help increase my diagnostic accuracy. This is a patient where we proved it was cancer. And what I did, I injected this lesion with ICG fluorescence, and using the Firefly system for the Tsai robot, I was able to see where this nodule was. I did a wedge resection here. And again, using I personally walked down to the pathologist. The pathologist evaluated the specimen and told me without any lack of certainty that this was truly a cancer. This is just a slide on a different modality that we sometimes employ at John Muir. This is called selectivity, or it's under the company Acquire, and essentially it's an optical microscope where I don't rely on the pathologist anymore to find cancer. You can place these specimens underneath this microscope, and essentially it helps light up these cancers for you. So what I equate it to, it's essentially the PET component of the CT PET scan. It helps light up cancer so you can really be sure whether or not you're seeing cancer or not here. And so as you see, as I showed you from the initial augmented fluoroscopy pictures, there was a CT to body divergence of 1.5 centimeters based upon the Monarch navigation system, pathway. By using Lung Vision, I was able to redirect the tip of my bronchoscope to where the lesion was in real time. And by, again, with the improvement in the spin and the tomography, I had 12% of the radiation exposure of the Tsai spin. We did 1 biopsy, and essentially they were both, initially diagnostic. However, when I put the specimen onto the Acquire system, I was able to demonstrate lung cancer in my optical microscope. So I had the confidence that I was definitely, getting cancer. And so essentially I marked the lesion in preparation to take this lesion out. again, it was cancer as well. Finally, the third case, as you can tell, we're actually getting better with body vision. I'm having more confidence in making sure that, I can go after ground glass opacities. This is a 77-year-old male with multiple, past medical histories. So pretty high Charleston comorbidity index here: CHF, hypertension, coronary artery disease. They had cabbage, and they had percutaneous stents placed for their coronary artery disease. He had a 40-pack year smoking history, no history of cancer, and this patient had a 1.5 centimeter ground glass opacity in the left upper lobe. And so you can see your CT images here. That is that solid component of the ground glass opacity. Here's your 1.5 centimeter ground glass opacity. And again, there's a little tip of that over there. And here is your intraoperative evaluation of the ground glass opacity using the lung vision. And again, look, here's your here's your tomography showing that ground glass opacity. And again, this was, quite honestly, very surprising for me, but all it did was increase my confidence that yes, body vision has the same resolution or degree of resolution as cone beam CT scan, with a fraction of the radiation exposure to us, and also the fraction of the cost for the hospital to absorb. And again, as you can tell, it really built up my confidence to use body vision for every single of my cases to really understand what was going on here. So you can see, here's my augmented fluoroscopy. These are still pictures. Because this is ground glass opacity, which is increased in size. Again, as I said, I didn't want to waste time to do these needle biopsies. So what I do for these patients who may have questionable sort of what we call lesion and tool, I place some sort of marker, whether it be dye localization, whether it be a coil. So this is an example where I place a fiducial coil, which is soaked in ICG, directly at the lesion. And then I go in robotically, I look for my green dot, because again, let's be very honest, there's no one who's going to be able to find this 1.5 centimeter ground glass opacity on direct visualization with any sort of bronchoscope. So I needed to help mark these lesions for me. And essentially, you can tell this is wedged out. I walked it to the pathology office, and again, they were able to confirm to me that this was adenocarcinoma. Now, quite interestingly, what it was when I walked this lesion down to the pathologist palpated the wedge resection I gave her, and she said, "I don't feel a lesion." And again, she's very experienced. I think she trained from Stanford and so on and so forth. So phenomenal training experience. And so she couldn't feel anything. She cut the lesion up in sort of that sliced bread sort of configuration to see if she saw anything in the middle, and all she could find was my fiducial. And she says, "Well, my concern here is if I waste any specimen or frozen specimen, we're not going to see cancer." So I said, "That's fine. I'm absolutely certain that my dye localization, my fiducial placement was accurate." So essentially, the next 2 days later, she called me on my phone and says, "Hey, you're right. We actually found invasive adenocarcinoma. In the past, we thought GGOs were going to be adenocarcinoma in situ, which a wedge resection would be appropriate. But for this patient, she had certain signs that were very concerning: invasive adenocarcinoma. There's a lipidic pattern. Again, it was still confined to the lung, but when you have those sort of red flags, this patient really should undergo the definitive oncological resection. So a week later, I brought him back for a trisegmentectomy, and the patient went home essentially 2 days after his surgery. So in summary, body vision provides true real-time intraoperative CT-like or CT quality imaging using a standard C-arm. Again, there's so many qualities to that hospital administration would find favorable, but more importantly, physicians would find favorable as well, because now you can actually have that confidence to make sure that the diagnosis of your biopsies and so on and so forth are much more accurate, because we place the targeting system on that fancy jet. And so by doing that, it maximizes the likelihood of diagnosis small, early stage lung cancers. And again, that is the trick, or that is the most important thing I feel that we can currently do now as a society, is to find these lung cancers earlier and earlier. So you can see our stage 1A lung cancer fully resected at John Muir Hospital actually doubled by using the combination of lung vision and robotic bronchoscopy. It increases and elevates the sensitivity and specificity of all our diagnostic bronchoscopy procedures. As you can see in my hands, I'm not only using for diagnostic bronchoscopy, I'm using for dye localization. And then finally, by doing that, it increases the diagnostic yield benefits for these patients Because what happens now is once these patients enter your lung cancer program, they're not going to some other hospital to get their their chemotherapy, their radiation. They all stay within our hospital program. So again, rising tide elevates all ships. All the different disciplines who treat lung cancer are the quality and the quantity of their patients are improved as well. And so again, in my hands, for these patients who have sub-centimeter lesions, where I know that it's probably going to be very difficult to obtain, Rose acquisition or Rose confirmation, I do dye localizations with either direct dye injection or fiducial placement. So that way, the wedge resection really helps me confirm that the lesion is evaluated under frozen specimens, which help improve the diagnostic accuracy of these lesions here as well. And again, more importantly, these patients are diagnosed, staged, and treated all within 4 hours, as opposed to that, again, I said that, spiraling system of referrals after referrals. So that concludes my talk. Hopefully I was able to address everyone's questions about body vision. Hopefully I was able to, articulate the reason why I feel having, true real-time targeting is extremely important for all these procedures. And again, I'll open up to any questions.
Thanks so much, Dr. Tsai. We have a couple minutes here for questions, everyone. If you have a question, feel free to submit it via the Q&A feature at the top of the program. So far, we've had a couple questions come through. So the first one for you, Dr. Tsai, is can you speak a little bit to how much time it adds to your procedure to be using both lung vision and robotics?
And it doesn't add time, it actually minimizes time. And the reason why I say that is because before I had body vision, I was in that pathway of rebiopsying, repositioning, rebiopsying again, because of the fact that, in the beginning, I don't think any one of us know what the true sensitivity or the accuracy of these robotic platforms. I was one of the first centers in the West Coast to acquire the Monarch. So, that sort of, play where you're just trying to tag different parts of the tumor to get a diagnosis, that was a big problem or a big, problem that I had because it added to a lot of insecurities of my diagnosis. So what body vision did was the fact that by doing those spins and readdressing or repositioning where the lesion is in true time, I didn't need to waste time of doing random biopsies along, the lesion. So now all I do is I make sure that the tip of the bronchoscope is pointed towards the lesion. My needle comes out. I do an RAO view, center view. If that tip of the needle is exactly still in the middle, you know that you're where you need to be. Sometimes you'll see maybe, for example, the needle is a little bit inferior to the lesion on your RA view, or anterior or posterior to your lesion in your RAO view. So then you make your adjustments there. So I'm not wasting time giving these specimens to the pathologist because of the fact that I know I'm not tool and lesion. So what's the point of trying to get them specimen? Only reason why I'm going to hand something off to the pathologist is when I truly have confirmation of tool and lesion. Because again, that's a rate limiting step for these procedures is waiting for the pathologist to sit there and dunk all their, all their dyes and so on and so forth to really look at it. So the specimens I sent to pathology, I want to make sure that I had tool and lesion because all I need them to do is confirm, did I have lesion and tool? That's what really is important here. So again, it really didn't add time. It actually saved time on the back end because I wasn't doing 5 different repositioning of the bronchoscopes in hopes of centering my lesion, my bronchoscope to the center of the lesion.
Great, thank you. Last question that just came through before we wrap. How many cases would you say it took for you to feel comfortable using lung vision?
So it's not lung vision that I had a problem with. And the reason why I say that is because of the fact that, again, to address the second question, these guys were supporting all the time. So, and quite honestly, the software in lung vision, and there's maybe one time where I added a case line and someone can fly down because the patient was inpatient again. And so, with the help of my staff, I have a phenomenal OR team. All we did was we read the screen of what body vision told us to do. We followed the instructions and, we had the same exact result. So for me, I would say it wasn't trying to use body vision that was a rate limiting step. for me, it was understanding how to incorporate those different views, the RAO views, the LA views, in terms of how to change the direction of my bronchoscope to be center lesion. That was what really I had problems with. But the workflow for body vision, it really tells you, center on the carina. Okay, well, how hard is that? You just center on the carina, push the button, next. And so the software itself is really, I don't want to use that word, but it's idiot proof. I mean, and so it's really easy to use. It's understanding what to do with that information was what took me time to figure out. But again, with the help of Freddie and Sam and stuff like that, I can really tell you, I feel very comfortable doing that now.
Fantastic. Well, thank you so much, Dr. Tsai, and thank you everyone who made time to join our webinar this evening. Hope you all have a good morning, afternoon, night, wherever you are.
Thank you, everyone. Have a good night.